You can also review the online office hours that have come previously and on our YouTube channel. Okay, so if you've not been on online office hours with me before, I try and cover as much information as I can in the hour. If it looks like I'm going to go over the hour, I do finish. And that way, because I want to complete it. If you do have to leave, you can always then go to the recording and pick up where you left off. Also, I do have you guys do a lot of questions. I think tonight we do some polling, but then I think we also have some multiple choice questions that are like exam simulated questions. All right, so let's talk about primitive reflexes. All right, so where is PEDS on the MPTE? Well, if you look at the content outline for the MPTE, all of the systems, it says across the lifespan. I think most pediatric questions you're going to see in neuro, right? But you could see some in musculoskeletal, and I think we do have an online office hour for pediatric musculoskeletal, and you might see some in cardiopulm, with like cystic fibrosis, but most of them are going to be in the neuro section. And so tonight we're going to cover a small part of PEDS, but we are going to cover primitive reflexes. There's also an online office hour on pediatric neuropathologies, and there's another one on the developmental sequence and development of gait. So hopefully you can check those out as well. All right, so what do you need to know for the MPTE? It's going to be very unlikely for you to get a question that says, what's an ATNR? Like, that's not really going to be the question. It's going to be, so at first you need to know what the reflex is, and how to elicit it and how to examine it, yes. And what would be a positive response, yes. But it's going to be more of a patient's presenting in this way, what reflex might still be at play. Or the patient has this reflex, what's it going to interfere with, or how are you going to change your treatment because they have it? Okay, so that's going to be more of the question that you're going to see. Can they ask when reflexes are integrated? Yes, and we're going to go over that at the end, and hopefully I'll give you an easy way to kind of memorize that or know that. And so it's really going to be more of those last two. How will the reflex interfere with function if it persists? What are you going to do differently? All right, so this one you're going to just put in chat. There are two primitive reflexes that you're going to see here when I get going with the video. And let's see if you can identify both of the primitive reflexes here. If I can find there we go. Okay, so in the chat, what did you see? Play it again. Okay, we've got people saying Babinski. All right, what else are you seeing? Plantar grasp. Okay, one more. What else are you seeing? Not stepping. Stepping would be, we're going to see that when we put them in weight bearing, but that's close. Cross extension, it could be cross extension potentially if I could see the other leg. So to evaluate cross extension, I have to see both legs. Can't really see what that other leg's kind of doing. But what are you seeing on the right? I'm doing a kind of a noxious stim to the foot, and they're doing, yes, a flexor withdraw. Nice job. Yes. So very good. Okay. So what I want to talk about right now with this reflex is the flexor withdrawal. Okay, so I did a noxious stim to the bottom of the foot. I just used my nail and just did a little thing at the bottom of the foot. And what do we see? We see flexion of the hip and the knee and dorsiflexion of the ankle. Okay, integrates really early. Now, if I pinprick the bottom of your foot, do you have a flexor withdrawal? Absolutely, right? But it when I say integrate, it's not so strong, right? If I say hold your legs still, and I come and I do a little noxious stim, like you could prevent that flexor withdrawal, right? So we see this exaggerated response young, and then it does start to integrate. All right, so in the chat, what will it interfere with if they continue to have a strong flexor withdrawal? Does not really integrate. What function is it going to interfere with? So in the chat, can you think of some things? Yes, weight, I'm sorry, weight, that's not what I meant to say. Walking, weight bearing, gait, standing activities, absolutely. So they're going to have issues with balance, gait, especially walking on uneven surfaces. What if they're walking on gravel, especially if they're barefoot, right? They're going to have some hypersensitivity to that stimuli on the sole of their foot. And then this can lead to gait abnormalities, okay, or abnormal gait patterns where they have this kind of abrupt stepping, marching kind of look of gait. And it's going to be hard for them. They're going to have that balance issue. Okay, so next question. So how would you adapt your intervention? So let's say they do have a strong flexor withdrawal and it is a problem and we have to deal with it. What might you do in your PT interventions because they have a strong flexor withdrawal? Any thoughts? I wouldn't walk them over gravel. Desensitization, we can try. Habituation, okay. Weighted footwear. Weighted. I like the footwear. So I definitely would want some kind of footwear or even orthotic that they wouldn't be getting that stimulus, right? So that stimuli wouldn't be, I wouldn't be initiating it all the time, right? So that's great. Yeah, I would do non-weight bearing activities. So if I needed to strengthen, I don't know, something, their quads or whatever, I might not do that in weight bearing, right? So I might do activities in different positions so that I'm not leading, they're not having that. Okay, so let's see what I've got. I've got avoid walking barefoot, right? They might need an assisted device if their balance is, if it's really affecting their balance. I will work on balance. Maybe they need a helmet. If they're falling a lot and I'm really concerned about balance, they may need a helmet. I'm going to educate caregivers about walking surfaces, shoe wear. I want appropriate shoes where they're not getting that stimuli, maybe even orthotic. And I like a lot of the other things you guys said about sensory integration and habituation and things like that. Those are things we can definitely try. There's not really good research saying that we can really impact the integration of a primitive reflex. So it's definitely something you can try, but we may have to go to these, we may have to work around the fact that they have this flexor withdrawal. Okay, name this reflex. So let me orient you this. I'm going to do a noxious stim on the right leg and it flexes. So it looks like a flexor withdrawal. But what I see on the opposite side, on the left leg, I see that leg extend and adduct. So what is this reflex? Yes, good. So we had already just talked about it. So yes, this is crossed extension. So this is the way I remember this reflex. It's like a flexor withdrawal. If I do a noxious stim to the right leg, I'm going to see that flexor withdrawal on the right. But what am I going to see? I'm going to see crossed extension. I'm going to see extension on the other side of the body. So does that make sense? Crossed extension. So I'm going to see extension on the other leg and adduction. Now, we don't know why we have all these primitive reflexes. We have an idea. The flexor withdrawal is probably a safety mechanism, right? A protection thing. Like if I stepped on something, if I'm a caveman, and I step on something sharp, I would flex that leg, right? We think we have this reflex because if we stepped on something sharp, our right leg would withdraw, but our left leg would extend and adduct to keep us upright so we don't fall. So we think that's why we have it. Okay, so same stimuli, noxious stim to the bottom of the foot. We'd see flexion of the hip and knee and dorsiflexion of the ankle on the right, on that particular side. On the contralateral side, we're going to see knee and hip extension and hip adduction. And again, this integrates really early. So you can kind of put these two reflexes kind of together. They have them early. It's the same, we elicit it the same way, just the response is a little different. Same as the flexor withdraw, right? We're going to have issues with standing, balance, gait, hypersensitivity, stimuli on the bottom of the feet, leads to abnormal gait patterns, kind of this, and again, the same as flexor withdrawal. So kind of lump these two together. Okay. Belly crawling. Sometimes students tell me, is it going to be an issue with belly crawling? Usually not, because when babies are belly crawling and they're using their feet, a lot of times they're using their toes. They're not getting a noxious stim like on the sole of their foot usually. So I guess you could see it, but typically not going to be an issue with belly crawling. All right. How do you elicit the positive supporting reflex? Do you know that one? How would you elicit it? What would you do to the baby? Yeah, very good. Put weight on their feet. Stand them up. So it's also called a positive standing reflex, okay, or primary standing reflex. So what we're going to do is just put them up on the balls of their feet on a firm surface, and what happens? They extend their legs. They stand, right? Primary standing reflex or reaction. Again, integrates really early. Okay. So what is this going to interfere with? If every time the infant's feet touch the firm surface and they're like in a standing position, their legs extend, what's it going to interfere with? Yeah. Squatting, bending over to pick things up, transfers. Yeah. So once they're up, if they have a really strong reaction, can they now bend their knees to squat, pick something up, sit down? No. Okay. It's also some of the same stuff. Are they going to have a problem with gait? Yeah. Balance? Yeah. Are they going to have problems taking steps when their knees are in extension? Yeah. Right. So we're going to have, again, that standing balance, gait, movement of their lower extremities, unable to move them forward, do flexion. They can get plantar flexion contractures because a lot of times they come up on their toes. And I think you can see that in the picture. They kind of come up on their toes. And if they're always doing that, we can get plantar flexion contractures. And you guys got it, squatting, sitting. And if they can walk, it's a very rigid gait pattern with very extended legs, extended knees. All right, so how are we going to adapt? All right, kind of the same stuff. Do they need an assisted device? Work on balance. Do they need a helmet? Educate. We're always going to educate caregivers. We're always going to monitor for integration of the reflex. We're going to monitor now for plantar flexion contractures. We may have to treat that, plantar flexion contractures. Maybe they need orthotics, okay? And we want to work on flexion of the legs in other positions, strengthen in other positions, and see if we can't get flexion while we're working with them. Hopefully this, integrates over time, and then they've got more voluntary control over flexion and extension of their knees. All right, you ready? Name the reflex. I'll play it again. By the way, all these babies, in all the videos, this baby is my son. He is now 26 years old. He was mortified when I showed him this about a month ago. He was like, "What?" I'm like, "Yeah, look how cute you were." He's like, "You're showing that to everybody?" I'm like, "Yes." All right. So, yes, it is the galant reflex. Nice job. I'm going to shut my door because the dog downstairs is barking. Maybe you can't hear it, but I can. Okay, galant reflex. Yes. So what am I doing? I'm stroking the paraspinals, okay, from top to bottom, and you can see the trunk then laterally flexes. Okay, so that's exactly how I'm going to test it. Put them in prone. You can even test it in sitting. You can stroke the paraspinals, And then you see that ipsilateral lateral flexion of the spine to the side that you just stroked. And again, it's going to integrate early, about 3 months. Okay, now, little different. What is this going to interfere with? If every time somebody touches my back and I laterally flex, what is that going to be an issue with potentially? Yeah, your clothing sometimes can elicit it. Yeah, when you're trying to nurse them, postural control, yeah. So sitting, right? If they're sitting and they lean back in a chair or somebody touches them or their clothes touches them, they could laterally flex. Could happen when they're walking and such as well. But, anytime there's some kind of stimulus, that can happen. Integrating to back to sleep. Yeah. Yeah, if we're putting them on their back to sleep, like we should be, to prevent sudden infant death syndrome, and they move a little bit, it could interrupt their sleep. Right? Very good. All right. So these are the ones I had. Sitting balance. It can actually help initially with belly crawling. Because if you look at the movement, right? So you can stroke their paraspinals and you'll see that arm and leg bend up and they get kind of that lateral flexion. Then you can stroke the other side. So if they have it, you might even use it to help you start with belly crawling. The problem is it's going to interfere when they don't, they elicit it when they don't want to, it's going to interfere. Can have issues with creeping, gait. Some kids have a really strong one that elicits a lot. It could lead to scoliosis. It also leads to, and this isn't really maybe PT, but just so you know, it can lead to a lot of fidgeting, inability to sit still, inability to concentrate, hypersensitivity to wearing clothes. And we see this some with individuals with autism, right? And so they still have this reflex, and that kind of adds into all these other things. All right, so how are we going to adapt? Okay, educate caregivers, work on our functional activities, maybe use the reflex to help them start learning how to belly crawl, monitor for scoliosis. It can also be the clothing that they're wearing. So are they wearing too tight of clothing that's rubbing on their back all the time? Or, maybe the clothing's too loose. So we may have to play around a little bit with the clothing. Maybe in physical therapy, when I'm working on their ability to learn how to sit, maybe I don't want clothes on, right? I mean, if it's an infant, right, maybe I say, let's take their shirt off to work on this. Because I really want to work on sitting. I want to work on strengthening. I don't want to be eliciting this reflex. So we may just have to work around it in that way. All right, you ready? Name the reflex. Okay. Yep. Good job. This is our stepping reflex. I'm going to do the video again. So you put them on their feet and lean them forward. Okay. So we might see that positive standing or primitive standing reaction, but then as we lean them forward, they might start stepping. So when my children were little and I took them to the pediatrician and the pediatrician would test this, he said to me, "Look, Mom, I'm walking." And I'm like, "Yeah, no, that's a stepping reflex." And he's like, "Okay, who are you? What do you do?" And I'm like, "Okay, yes, it's just a reflex." But all right, so let's look at it. Right, we hold them up, put their feet on the surface, lean them forward. And what did we get? High stepping movement, regular rhythm, robotic looking. Again, should integrate early. We want this to go away, right? It can help. I mean, if it stays, it can help with initial gait, but what's going to be the issue as we go on, right? What is it going to interfere with? It's going to interfere with volitional walking. And their standing balance and the ability to stand without stepping. So I treated a 12-year-old that had a really strong stepping reflex, and he walked very robotic, real high stepping robotic. He had a lot of issues with balance, and he could not walk alone. He always had to have somebody walking with him. He could walk, but it was dominated by this reflex. And he also had a lot of stair seizures, and so he really couldn't walk by himself. He was very high fall risk. Now, when we got to the stairs, he would he would step right up on that step, to do stairs. Coming down was a little bit more difficult, so we did have to work on stairs, but so it did interfere with his ability to be independent with walking. All right, how are we going to adapt our PT treatment? Educate caregivers, evaluate, maybe they need an assisted device. He because of his stair seizures, we couldn't even use an assisted device. Maybe handheld ambulation, work as much as you can on balance and upright skills. But his was so strong that, and he was 12 at that point. So we knew it probably wasn't really going to integrate, and we had to just deal around with it. Okay. What reflex would present with overall flexion of the body if I lay the patient prone, but overall extension if I lay the patient in supine? Tonic labyrinthian. Very good. Yep. Tonic labyrinthian. Yeah. So let's look at it. So the classic reflex of tonic labyrinthian is, if I put them in supine, they go into overall extension. If I put them in flexion, or if I put them in prone, they go into overall flexion. Okay, look at these two pictures. If they have a really strong tonic labyrinthian, and every time I put them supine, they go into extension and they're kind of stuck. And every time I put them in prone, they go into flexion and they're stuck. What is that going to interfere with? And a million things should be going through your brain right now. So what will this reflex interfere with? Bed mobility, absolutely. Yeah, creeping, crawling, yes. Sleeping, moving in sleep to change their position, yes, absolutely. Nursing, yes. A million different things, right? If you look at those two pictures, even Therex, right? If I put that person supine on the mat to do Therex and they can't bend up their hips and knees, I can't do Therex in that position, right? So it's just going to interfere with so much. Prone propping, right? I want them to prop on their elbows or extended arms, and they just go into this flexion. Rolling, either direction rolling, prone to supine or supine to prone, belly crawling, creeping, transitioning out of these positions, bed mobility, but transitioning into sitting. It also negatively affects their orientation of their head and their ability to control posture, and they can have poor visual perception. So all of these things. So this one's tough. How are you going to adapt your treatment? Any thoughts in chat? How are you going to, if they have a strong tonic labyrinthian, now I'm trying to work with them in PT. I guess it depends what I'm doing, but any ideas how we might manage around this? Yeah, so we might get them out of this position to do exercise. Maybe I want to have them in sitting to do exercise, standing to do exercise. You guys said sideline, sure. So I might try different positions. Maybe I'm trying to strengthen, or, I don't want them in these positions to do that. Okay. So educate caregivers, monitor for integration, place in different alternate positions appropriate for strengthening. Hopefully this lessens and they're able to get more voluntary movement, and we can proceed with our developmental sequence. But if it persists and it's really strong, this is what's going to happen. We may have to educate caregivers about, going in and changing positions through the night because they can't roll over or change positions. And maybe we even get some kind of device that has, helps them roll, or get them some kind of positioner that keeps them in sideline, but something, we're just going to have to deal with it. All right. Name the reflex. And this can be two different ones. So I'll take two different answers. But what do we got here? All right, let's look at it again. Okay, I got people in chat telling me Moro reflex. Yes, yes. Okay, so the Moro reflex, I'm going to show it to you again, is basically when they feel like they're falling backwards. So you see how they have the infant kind of up, and what they do is they let them fall backwards or let their head fall backwards. And so they get this sensation that they're falling. And what does the infant do? The infant abducts their arms, splays their fingers. Okay, woo. And then what happens? Their arms come back down and their fingers relax. Okay, that is a Moro response. Okay, so we allow the head to drop back when a reclined position. Make sure you're there to catch their head. Okay, especially little babies, they don't have good head control yet. Let's make sure we're ready to catch their head. We get abduction, extension of the upper extremities, splaying of the fingers, and then it's followed by bringing their arms back down and pulling them close to their chest, their fingers relaxing. It should integrate about 3 to 5 months. All right, what is it going to interfere with? I'm going to get to the other reflex in a sec. What will this interfere with? Sitting balance. Yep. Standing balance. Yep. They look up really quickly. They can elicit it. Okay. If they're sitting and they lose their balance, are they going to be able to catch themselves as they start to fall backwards? No. They're not going to have a protective reaction to keep themselves from falling because their arms are going to come up. We don't want that, but that's what's going to happen. Okay. So it's going to interfere with sitting balance, standing balance. They can be over sensitive to looking up or falling backwards. They're going to have problems with supine to sit. As adults, they can have issues. They may not be able to drive. They may not be able to play sports. And so hopefully it doesn't persist into adulthood. All right, how are we going to adapt? Educate caregivers, monitor for integration, work on sitting balance, maybe in a secure environment. Something where they're not going to be stimulated to look up really quickly, have safety in case they do fall back, they're not going to hit their head, use of a helmet, all of those types of things. Okay, so here's my question. What's the difference between a startle reflex and a Moro reflex? Because that also looked like a startle reaction. Now, a lot of people just lump them together. They're like, oh, a startle reflex is the same as a Moro. I don't lump them together because there is a difference between them. What is the difference between them? Yes, it's the stimuli. So a startle reflex, the stimulus, it's the way they're elicited, the stimulus is a loud noise, a sudden movement, or a bright light. So now, do we all have a startle reflex? If I come up behind you and go, boo, right, you're going to have a startle reflex, right? But I just did that. Did you all startle? Probably not, right? So the startle reflex, though, in babies when they're little is exaggerated. I mean, the littlest tiny noise or movement or bright light will startle them, okay? And so we want to see it lessen to the point where every little stimuli is not eliciting it by that 3 to 5 months. So, but the response is the same. They're going to get the abduction, the extension, the splaying of the fingers. It's all the same. The difference is the stimuli. All right. So what's it going to interfere with? Oh my gosh. They can be so much reactive to sensory stimulation, right? They can be hypersensitive, hyperreactive. They can be easily distracted, can lead to issues in school, poor interaction, attention, inability to do fine motor skills, especially in a loud environment, can affect sitting balance, standing balance, all the same kind of stuff. So this is, I think, a little on the easier side. How would you adapt your PT intervention? All right, this child has a very strong startle reflex. They also have cerebral palsy. They're coming into the clinic and I'm going to be treating them. What am I going to be changing in my my environment? Yeah. So I'm going to have them in a private room that's quiet. I'm not going to have a lot of toys with bright lights that are going off or loud noises, right? Mom and I are going to talk quietly, all of that. Hopefully the reflex will integrate, but I'm going to be thinking about the environment because I'm trying to get other things done, right? I'm trying to teach them these skills and because they have cerebral palsy. And so I don't want this startle reflex interfering all the time. So kind of the same things, educate and monitor, do they need a helmet? Do they need supervised during certain things? And ensure that safe environment, but also modify your environment. Avoid the stimuli during PT. That'll be helpful for you to get through your PT sessions as well. All right, you ready? Name the reflex. You only wanted to look to one side, but I tried to get him to look to the other side. Okay, I think you guys got this one, but just putting it there. Okay, so ATNR, yeah, asymmetrical tonic neck reflex. So what's the stimuli? Head rotation. Now, I had him, again, this is my adorable 26-year-old who was about, I think here he was about 2 months old. So here I was trying to do active, but you can also passively rotate their head. I always go for active first because I don't want to be rotating a baby's head and being forceful with their head for sure. And so when they look to let's see, he's looking to the left. The arm on the face side extends, the arm on the skull side bends. Now, if he goes and looks the other direction, the arm that's bent will extend and the arm that's extended will flex, okay? Now, I don't struggle to remember this one, but somebody told me once, remember an archer with a bow and arrow. That's kind of what they do, right? The face side, they're extended, and the skull side, they're pulling back their arrow. So hopefully that'll help you remember. A lot of students get symmetrical and asymmetrical tonic neck reflex mixed up. Do you see how this is asymmetrical? The arms are doing two different things. Also, you can't really see his legs very well, but a lot of times the legs will come into it as well. So you definitely can see the right leg is flexing and it looks like the left leg is extending. The leg will come into it as well. Okay, so how do you elicit it? Rotation of the neck. Okay, we talked about, what's happening. This picture, you can also see the flexion and extension of the leg as well. Should integrate around 4 to 5 months. All right, what is this going to interfere with, guys? So many things. Rolling. Yeah, let's look at this baby. They want to roll to their stomach. Their arm is in the way, and they can't reach the other arm across. Okay, if they're prone and they turn their head and they go to roll, the one arm's going to flex and the other one's going to extend. It potentially, depending on what position they are in, it could potentially kind of help with the rolling, but probably not. Crawling, yeah. Crawling. Yeah. All right, let's look what I got. Oh, so many things. Right prone propping, rolling, belly crawling, creeping, sitting balance. Okay. If they need their arms to bear through their arms as they're first learning to sit, every time they turn their head, one arm is going to bend. Okay. Now, once they can sit upright without the use of their arms, it's not going to interfere so much. Gait. Yeah, if they're up and walking and they're turning their head, first of all, it's going to be hard to use an assistive device, but also if their leg is pulled into it, that's going to be an issue. I have an OT come into class and talk to my students about fine motor development in babies, and she always makes a big point to tell people this reflex, if it persists, will affect every fine motor skill. They cannot cross midline. They can't do anything by manual. Let's say this baby is looking at you and you give them the bottle and they're holding on to the bottle and then they turn their head to look at mom. What happens? They drop the bottle. Okay. It also can lead to torticollis. So, and then torticollis, can lead to plagiocephaly. So all kinds of things. Yeah, assuming quadruped's going to be a problem. Yeah. all kinds. Okay, so we really hope this integrates. We're going to refer to OT because fine motor is going to be a big problem. The OT needs to get involved. We're going to monitor for that torticollis plagiocephaly. If I'm working on sitting balance and they need their arms for support, again, I'm going to be thinking about my environment. Mom's going to sit directly in front of the baby. The toy's going to be in front of the baby. I'm not going to have distractions where they're looking side to side, right? I'm going to adjust my environment. Again, I'm educating caregivers, looking for integration, working on trunk, not truck, working on trunk strength in sitting so they don't need their arms to sit, right? And so that reflex won't affect it as much. And then hopefully as it integrates, we can do more and more interventions. Now, I just want to tell you a story. I treated an adult who had this reflex, strong reflex. He was nonverbal, but very intelligent. He actually wrote stories on his computer with eye gaze because he couldn't type. Could you imagine? Oh, but he was very intelligent. If you were walking by his wheelchair and he wanted your attention, he would rotate his head to look at you and his arm would fly out and hit you. And so he was smart enough he could use it to his advantage to say, hey, I need you, or I want to talk to you, right? But it would be good if it had integrated and he wouldn't have that issue. All right, name the reflex. This one's easy. In fact, it's so strong, I'm struggling to even try and elicit it. I'm like, let me get in there. Yeah, and then look how strong it is. Right, so you guys got this one, palmar grasp. Yeah, so his palmar grasp is so strong that I'm just trying to open his hand to put my finger in there to elicit it. And then once he has a good grasp of it, you can see how strong that is. Okay, so we're going to elicit that by just putting pressure to the palm of the hand. Again, pediatricians are like, look, mom, she's holding your, the baby's holding your finger, holding your hand. And it's like, yeah, that's a reflex, but that's nice, right? And so the response is finger flexion to grab whatever's in their palm. Integration is 4 to 7 months. Okay. How's it going to interfere? Yes, it's going to interfere with fine motor. Absolutely. They don't have voluntary grasp and release. Whatever you put in their hand, they grasp, and then sometimes they can't release it. What gross motor issues are we going to have? Will it affect gross motor? Absolutely. What are they going to struggle with gross motor wise? Learning to stand. They can't pull up on the couch. Well, they can learn to pull up onto the couch with fisted hands. But it's better if they can open their hands and grab onto the couch to pull up. So it's going to be difficult for them to do that pull to stand. Yes. Transfers. Yeah. Okay, good. Yeah, if they need to hold on to something to walk, yeah, they can't do that. Okay. What activities when they're really little do we actually want them to weight bear on open hands? That if their hands are fisted, might be problematic. Crawling, yes. Prone propping, crawling, creeping. Can they do it on fisted hands? Yeah, but it's going to be a lot harder. They're going to struggle with balance. They're going to be delayed because they can't open those hands to get a nice base of support. They can't pull with their hands. Cruising is going to be problematic. Yes. Right? Okay. So it will interfere with gross motor skills. Okay. All right. How are you going to change your intervention? I've treated a lot of kids with a very strong palmar grasp, even into, later years, not just infants, but later on. And sometimes some of our kids with mild CP, like this is the only strong reflex they have, and we have to work around it. So what would you do? How would you adapt your PT intervention? Open chain without having them hold on to anything? Sure. Change the position, if you're working on strengthening, Maybe there's different positions where they don't need their hands or what have you. Yes, hand splints. Yep. So I'm going to pull in the OT again, right? So again, refer to OT. They might need a hand splint. So a lot of kids will have these soft hand splints that help open their hand, or maybe they've got one piece of it that's a little hard and the rest is kind of soft. A lot of babies, we do more of a neoprene thing to open their hand. And then that way in PT, when I'm trying to teach them the prop, crawl, whatever, their hand is open. Okay. And that can help with their balance and everything. And again, they can move along the developmental sequence with fisted hands. And it's okay as long as they're not developing, wounds on their hands or secondary impairments, but it's just going to be a lot harder for them. So I might want to move them along their developmental sequence a little faster if I have a hand splint. Great. All right, what reflex would cause flexion of the arms and extension of the legs when the neck is flexed? What reflex is that? Yep, STNR. Yep, very good. STNR. Good. All right. So an STNR is flexion or extension of the head, either actively or passively. This is symmetrical. So the arms, both arms are doing the same thing. Both legs are doing the same thing. So remember, ATNR, one arm was doing one thing, one arm was doing the other, and same thing with the legs, right? That was asymmetrical. So try and keep that in your brain. Now, as a new pediatric PT, I struggled with this. I'm like, okay, when I do this with the head, what do the arms do? What do the legs do? Blah, 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 right? So hopefully this will help you. This is the way I remember it now. Whatever the head does, the elbows do. The legs do the opposite. So when I flex the head or the neck, the elbows flex. The legs do the opposite. If I extend the head, the elbows extend, my legs flex. So whatever the head does, your elbows do. Your legs do the opposite. So here you can see a picture of somebody in supine, but then you can also see somebody in sitting, right? So if they're sitting and they look up, they extend their head, what happens? Their elbows extend and their legs flex. All right. If they look down at their toy, their elbows flex, their little nose hits the ground, and their legs are trying to extend. Okay, integration is later, 8 to 9 months. Okay, what's it going to interfere with? Again, so many things. What is it going to interfere with? Crawling, yes. Creeping, yes. Got any more? All kinds of things. All right. Prone propping. They would have to be looking up to prone prop on extended elbows. They would have to look down to prone prop on flexed elbows. Belly crawling, creeping. Sitting balance if they need their arms. So I'll tell you a story. I had a child I was treating, and we were working on sitting balance. And I had the toy on the ground, and he kept collapsing. He'd have this slump posture, his elbows would bent. He was playing with the toy, but I couldn't get him to sit up. And I kept thinking, oh, I got to work on trunk strength. I need to work on tricep strength. So I would put him on a therapy ball, one of those great big therapy balls, prone, and I would roll him out, and he would look up at mom. His arms would extend, and I'm like, what's going on? Like, he looks like he has great tricep strength. And then I realized, oh, he has an STNR. So the next time I put him in sitting, I put the toy up on a bench where he had to look up. What do you think he did? Boop. He sat up, super nice, with nice extended elbows, nice trunk. I'm like, oh, I can't believe it took me like 2 weeks to figure this out, right? So it was the primitive reflex. You can read the rest. Problems with transfer, standing balance, gait, hand-eye coordination. Again, it's going to affect some fine motor. The inability to dissociate between lower extremities. So their lower extremities are wanting to do the same thing versus one will flex and one will extend, can lead to W sitting. So if I go back here, You see them sitting, they sit back on their heels. Very easy for them to just drop down into a W sit. So that's going to be a problem as well. Okay. Eye tracking, yes, that's going to be a problem as well. How are we going to adapt? Recognize the reflex. That's what I didn't do. I mean, all of these, we want to be able to recognize what's going on. Educate. Think about our goal again. If I'm doing strengthening, can I do it in a different position? Maybe they're older now and I don't need to work on belly crawling and stuff. Maybe I just need to work on, walking. Think about your toy placement. Monitor for integration. Monitor for proper development of the spine. They can get kyphosis, so we would watch that. Maybe they need equipment for sitting, so they can sit upright. If the child's older and cognitively intact, they may have to pay attention to their neck positioning. Try and prevent that W sit, give them other options. Again, may have to revert to OT. All right, this one's super easy, but name the reflex. Yeah, people know it. They're just typing. All right. Yeah, it's not the palmar grasp, it's the plantar grasp. Yep, you got it. All right. So this integrates about 9 months. The way I remember this one is it needs to integrate so that I can walk independently. So this should be integrated, but by the time I'm you might see kids pull up to stand and start cruising with it. But by the time I'm doing independent walking and taking my first steps, I'm hoping this one's gone because it will affect my balance, right? And so, yeah, it's going to affect my standing balance, walking, running. How am I going to adapt, educate? This is the kid that every time you're putting on their shoes, their toes curl. So we want to educate the caregivers and make sure when they're putting their shoes on, they're not putting them on with these curled toes. So they might actually need an orthotic just for donning shoes, but they might also need one to prevent it so that they have good balance and we can proceed with independent walking. Good footwear. Consider our walking surface. I probably don't want to walk them barefooted. And monitor for that integration. Typically, I want infants to walk barefooted. Why? Because walking barefooted develops the muscles in the feet and helps develop their longitudinal arch. So usually I don't want an infant always walking with shoes. But in this case, I might need some time. We may need orthotics for when we're really trying to get them to walk a good distance or to do independent walking. All right, you guys know this one. I couldn't find a baby, but you guys know what that one is. Yep, Babinski. So some of you picked that up in the very first video, and I'd have to go back and look at that video very carefully to see if I see a Babinski, but there might have been a Babinski there too. We had flexor withdrawal and plantar grasp, but there might have been a Babinski as well. Now, what you need to know that this is normal in an infant. So we want to see it. It's normal. But by the time they're about 2, it should be going away. So you've probably learned it with adults, right? If we see it in an adult, that's like a sign of an upper motor neuron lesion. But in babies, it's normal. So we expect to see it until they get, over 2. But it could interfere again with some things. Typically not so much. They're going to have shoes on, or, it just doesn't, the splaying of the toes doesn't really affect it too much. But it could. So that's why I have maybe. And again, it's the same stuff as what we were talking about with the plantar grasp. And, if it persists, they're 2, 2.5. I'm thinking, is this because they have CP? Is there an upper motor neuron lesion? Maybe at that point, that's why they have it, because it hasn't gone away, or it's really strong. I might be thinking about that. And maybe they're seeing me because they have a delay, and I'm already thinking something else is going on. Okay, so You could be asked when reflexes interfere. Oh my goodness. I actually presented them to you in order. I do not think that you're going to be asked when they start. And honestly, I don't have that memorized. I know at birth, all babies should have all of these, except maybe the STNR. I think that's all you need to know. At birth, they should have all of these primitive reflexes, except maybe the STNR, because it's not present in all children. Okay. So what I think is more likely you're going to be asked about is when does it integrate? So if you see, there are a few that integrate early and there are a few that integrate late. All the rest are in this like 3 to 4, 5 month period. So if you're struggling, I would know the outliers, okay? And that's going to help you. And again, the plantar grasp and Babinski, I'm thinking I want those to go away before they walk. Now, the Babinski can last up to 2 years, but usually it's integrated by the time they're walking. So those are how I remember that. Are there other primitive reflexes? Yeah, there's rooting, sucking, gagging, but I don't worry so much about those. I know about them, but OTs and speech therapists are going to be so more concerned about it. Okay, we only have 8 minutes, but I want you to see if you can answer these 8 questions, put it all together, and we are going to use polling. And so let me get the poll started. All right, we ready? Let's see if we can put it all together. A child's having difficulty sitting independently. A physical therapist decides that this may be due to a primitive reflex that has not integrated. Which of the following would be most important to evaluate is it can directly impact their ability to sit? Now, on the MPTE, when they give you multiple answers in each, if one of those is wrong, the whole thing is wrong. Look to see if it shows up again, and then that's going to be wrong, right? So the entire answer has to be correct. Okay. That's how they get you sometimes, right? Because you're like, well, this one will, but I'm not sure about that one. That's right. So you got to look for the two. All right. So I've got 70% of you. So I'm going to go ahead and end the poll and share the results. So we're down to 1 and 4. That's what most people said. Okay. So let's look at the answer. Okay. Sorry. Write your answer down. I should have picked, wait a minute. Let me stop. Okay. Let me do this. Stop sharing. I forgot that we're going to answer all 8 in a row and then I'm going to go over them. I am so sorry. So I only have one with 10 questions, but that's okay. Okay. So I just launched it. So whatever you said for number 1, put it in now for number 1. Okay. Give you a few seconds to do that. You're going to answer all 8 and then submit your poll, and then we'll go through all 8. Okay. And I can't see how many have said what, so I'm going to give you about a minute per question. Get my timer ready. Okay. So hopefully you entered the answer for this one. All right, number 2. When evaluating a child, a physical therapist decides they still possess a strong STNR. Which of the following would best describe the finding? All right, number 3. Don't submit your poll till you answer them all. A physical therapist places an infant in prone, and they curl into a fetal position and appear to be unable to get out of this position. Which of the following is the most important to assess, as it has likely not integrated? All right. I'm going to move a little quicker than a minute per question because I think you guys got this one. All right, let's look at number 4. A physical therapist thinks that an infant being evaluated has a strong Moro reflex. Which of the following response would be positive for a Moro reflex? All right, I bet you guys got this one too. Let's keep going. Number 5. A physical therapist evaluating a 12-month-old infant decides a referral to an occupational therapist is warranted due to persistent primitive reflexes that will interfere with the development of fine motor skills. Which of the following is the therapist most likely concerned about? So which ones are we most likely concerned about that's going to affect fine motor skills? All right, number 6. Which of the following primitive reflexes would most interfere with the child's ability to learn to belly crawl? All right, let's look at number 7. Which of the following would a physical therapist be most concerned about regarding safety when teaching a child to ascend and descend the stairs? This is a question I actually don't like very much, but I'm going to let you answer it and then we'll talk about it when we get to the answers. All right, and the last one, number 8. A child who is 3 months old typically cannot roll supine to prone. Which of the following is the most likely reason for this lack of rolling? All right, you can submit your poll now. And I know it's after 8 o'clock. I typically do run over. I apologize. I will finish. If you have to hop off, thanks for joining, and hopefully you can catch it on the YouTube, the recorded on the YouTube channel. Yeah, I don't have 9 and 10. Yeah, just submit it. There's only 8, but I only had the poll ready that had 10. So I don't have the extra 2. Okay. All right, so I'm going to go ahead and end the poll. And I'll share the results with you. All right, so number 1, we said A or D. Let's take a look. A. Okay, child's having difficulty sitting independently. Which of the following is the most important to evaluate their impacting of sit? Okay, so the symmetrical tonic neck reflex, again, if they're learning how to sit and their legs or their arms are flexing and bending with their head, it's really going to be difficult. Again, the gallant will make them laterally flex. The ATNR, it will affect it a little bit, but not the crossed extension, because when they're sitting, their feet aren't touching the ground. There's no noxious stem. Crossed extension is a weight-bearing reflex. We can test it in supine, but when they're sitting, it's not really at play. The Landau reflex, we didn't really talk about that, but that's like when you suspend them in prone and their head and their legs come up. So not so much. Startle reflex, yes, that will interfere with sitting. But again, we got to have both things to be able to do it. Moro reflex will absolutely interfere with sitting balance, but not the positive supporting reflex. Remember, that's the standing reflex, so that would not. So again, we want to pick the 2 that would. Okay. And this is a Landau reflex. Okay. So, okay. Okay, so that's not going to affect sitting. Okay, so 2. What do we have on polling? Yeah, 93% of you got the right answer. Nice job. Yeah, so this was just what is an STNR? And you guys had it. If we flex their neck, remember their arms or elbows do the same thing, their legs do the opposite. So it's just the definition of it. Nice job. Yeah, if we lay them in one position, they, prone and they curl into that fetal position. What is that? Tonic labyrinthian. Good. Almost 80% of you guys got that one right. Yes. All right, number 4, 90% of you said A. Let's see, is that the right answer? It is. Yep. So again, it's talking about positive response for the Moro reflex. So again, just seeing if you know what that positive reaction is. Okay, number 5. So what most warrants the referral to the OT or your concern about fine motor? So 70, almost 80% of you said this. Right. So the ATNR, remember what I said? It affects every fine motor skill. They can't cross midline. They don't have good hand-eye coordination. They can't do bimanual skills. Palmar grasp. If they have a strong palmar grasp, I don't think I said this. So when a baby who has a strong palmar grasp makes a fist, their fingers then elicit that palmar grasp and it keeps their hand fisted. And so they don't then have voluntary release and grasp. So B, symmetrical tonic neck reflex. Yeah, I mean, it can affect fine motor a little bit because when they're moving their head around, their elbows are flexing and bending, but not as much as those other 2. And if they keep their head in one position, they can do their fine motor stuff. C, tonic labyrinthian, that's if they're prone or supine. that would interfere with fine motor, but a lot of our fine motor stuff is in sitting, right? Eating, writing, and that wouldn't affect it because they're not in that supine or prone position. Gallant a little bit, yeah, but more so our ATNR and Palmer grass. All right. Which one would most interfere with their ability to belly crawl? Good. 83% of you said C. Yeah. Because as soon as I put them prone to belly crawl, they're gonna curl up into that fetal position. The parachute reaction, if you don't know what that is, that's a protective reaction. If I hold a baby up and take their head down towards the floor, they put their hands out to prevent themselves from hitting their head. I want a parachute reaction. I don't want to see that go away. But it's not going to affect my belly crawling. Crossed extension, again, it's a weight-bearing reflex. It's not going to really have an issue with belly crawling. Plantar grasp, they have a plantar grasp. Remember, when does it integrate? 9 months. Do babies belly crawl before 9 months? Yeah. So it doesn't interfere with their belly crawling. Parachute, just if you've never seen it, really quickly. Positive. This is a negative. Okay. Does not have it. Positive. Yep. Good. So we want to see that. That's a good thing. All right. Number 7. I think this is the one I don't like. Yeah, we were all over the place. I don't like this question. Let me tell you my thinking, but I don't think it's probably the best question. So I'm thinking if they're going up and down the stairs and they have an ATNR, I'm thinking about them holding onto a rail. I probably need to change it so they're holding onto a rail. If they have an ATNR and they're moving their head, their arm is flexing and bending, right? But I think they could potentially get down the steps. Tonic labyrinthian would be if they're prone or supine and they're standing up, going up and down the steps. So that one I don't think. I have had kids with a plantar grasp reflex who can go up and down the steps because they're holding the rail and their toes curl, but they can go up and down. But what I'm really concerned about is a really strong startle reflex that somebody goes boo and their arms fly up, and that I think is the biggest safety issue. But I can see an argument, especially for A. So I think if you said A or D, like, give yourself the point. I think it could be a better question. All right, and the last one. Why can I not roll? This was maybe a little tricky one because you had to get rid of some of the primitive reflex ones. People answered 9 and 10. That's funny. Okay, so number 8, yeah, most people said B, right? So this says at 3 months, why can't they roll supine to prone? Because they integrated the STNR. No, it's not integrated at that point in time. They still have a strong palmar grasp. Yeah, they do, but that has nothing to do with them rolling. Or that's not the reason they can't roll. They're still developing neck writing reactions. I mean, maybe, but that's not really helpful. So it is the inability to have anti-gravity, trunk flexion, abdominal strength to roll. So that was a little bit of a tricky question because you kind of had to get rid of the primitive reflexes one. All right, hopefully you know what neck writing is and you know what trunk writing is. Primitive reflexes, if you have our course manual from our 2-day course, is in the neuro chapter. And if you have our large review book, it is in the pediatric chapter. And I am the author of that pediatric chapter. Here is my adorable son again, showing you the rooting and sucking reflex. He's 26, but he's still cute. All right, there's my email. Any questions that you guys have? Oh, you had to fill in 9 and 10 to submit it? Okay. I'm like, why? I'm like, that's funny. Everybody put something in for 9 and 10, but I love it. All right, so thank you for joining. Oh, next week, it's heart failure, CPGs. So this is the schedule if you're taking the exam in April. We have another schedule online that takes us through July. So we have all of our online office hours scheduled through July. And we actually have about 30. So if you want to listen to some other online office hours, like I do one on GI, lymphatics, integumentary, we have a bunch. Check it out on our YouTube channel. Thank you guys. Have a good evening. Sorry I ran late, and hope to see you again on another online office hour. Oh, I'm doing pediatric neuro in a few weeks. So hopefully I'll see you back then.